Hi everyone, we're going to be talking about pulmonary rehab assessment. So please make sure that you're reading through all of these resources that's mentioned in your syllabi. So Kisner and Colby, chapter 27, O'Sullivan, pages 572 to 586, and chapter 12, Pearson, chapter 10, and then we're also going to be looking in the Score Builders textbook. So mostly chapter 6, on pages 384 to 394, 475, 607, and 613. So make sure you're reviewing all that information. I'm going to kind of be jumping back and forth. Make for sure that you review all the anatomy that's mentioned in the Score Builders textbook on page 359. Talks about the thorax, talks about the muscles of inspiration, muscles of exhalation, the upper respiratory tract, lower respiratory tract. So make sure you know that information as well. And I'm at home recording this, so please ignore my dogs. As you can see on page 360 in your Score Builders, is that there's a difference between the left lobe and the right lobe. The right lobe has, or the right main, I say lobe, has 3 different lobes. As you can see, compared to the left, only has 2. So make for sure you know this anatomy and be able to label it. We're going to be really talking a lot about lung volumes and capacities. On page 361, you're going to have to memorize all of those definitions and any of the definitions that are mentioned on these next couple pages as well. So make sure you're reviewing all this information. But first, we're going to talk about inspection. So inspecting someone, especially like, if you're in the hospital setting, acute care setting, or it doesn't, or it may be in skilled nursing facility, home health, any of these different settings, you're going to be checking for someone. Now, a lot of these issues are going to be ones that have some kind of diagnosis related to pulmonary or cardiopulmonary. So you're going to check for breathing rate, quality, appropriate muscle activation. You're going to be taking all their vital signs as well. Observe signs for hypoxia. Do they have cyanosis, like that blue coloring on the nail beds? Do they have chronic digital clubbing, fingers or toes? This is more advanced and more significant clubbing angle. You'll see in this next slide. Definitely, I've seen a lot of patients, that have cystic fibrosis, that have the clubbing of the fingernails. But COPD patients, chronic obstructive pulmonary disease, emphysema. So we need to be able to be aware, and so especially if someone has cyanosis, it's definitely important to check their oxygen level with the O2, or check their O2 saturations with a pulse ox. So here's some different pictures of what that looks like for cyanosis. Just a discoloration of the nail beds, of the lips, the tongue, and then this would be more chronic condition here of the clubbing. There are some other handouts on Blackboard available that are from PhysioU. It talks about assessments, so make sure you review those and what that would look like. And there are videos if you wanted to click through the PDF file. And you can also just locate on PhysioU as well. So make sure you review those handouts for assessment. The next thing we're going to talk about here, well, before I move on so the other things to observe that's really important is looking, the accessory muscles with ventilation. Are they using, accessory muscles of like the upper tract muscles just to make for sure that they have more of a diameter of the thorax? Are you able to see that with this patient? There are different measurements that you could do with a tape measure to measure the anterior posterior diameter of the chest wall during inhalation and exhalation to see if they are symmetrical as well. Okay. All right, so moving on from that. So now I'll talk a little bit more about lung oscillation. So make for sure you're looking at all of these points in your Score Builders textbook, page 378 to 379, but definitely look at these definitions as well. The definition involves listening over the chest wall as air enters and exits the lung. You use a stethoscope firmly in place of the thorax anteriorly, laterally, and posteriorly. I'm sure you've had this assessment before if you've ever been to your physician and they tell you to take a deep breath in with your mouth and then slowly exhale quietly. And so this is how you can listen and see if it produces a soft rustling sound. The end of exhalation is normally silent. So characteristic of normal breathing sound is called vesicular, when a loud, more hollow and echoing sound occupies a larger portion of the ventilatory cycle. The breath sounds are referred to as bronchial. When the breath sounds are very quiet and very audible, they are termed decreased. So these three terms are able to be used to identify and describe the intensity of the breath sounds. So there's also additional sounds as well describing the intensity or vibrations heard. These are called avitation breath sounds. So they are already described intensity of the breath sound as well. There are two types of avitation sounds, crackles and wheezels. So this would be like abnormal. So crackles, previously termed rales or rhonchi, sound like the rustling of cellophane and have a multitude of potential causes. So this could be due to tissue fibrosis, secretions in the airways, pulmonary edema, or there could be other issues as well. Wheezes have been described as a high-pitched, coarse whistling sound. A decrease in the size of the lumen of the airway will create a wheezing sound, much like stretching the neck of an inflated balloon when you're narrowing the passageway where the air will escape. And this produces the sound. So all of these sounds are located on Blackboard, and there's also a handout on there with links as well. So make for sure that you're listening to all of those breath sounds because they will be on your exam. And again, you will need to have either headphones or AirPods or some kind of listening device for the actual test so you can listen to them. We're going to be talking a little bit later, but make for sure too. So if you look at page 378, there's 379 in your Score Builders textbook, they tell you about the normal breath sounds, the abnormal breath sounds. Make sure you know the differences and their definition too. So briefly talk about dyspnea, but this is really on the last slide to tell, there's different measurements to describe. I think this is on page, 380. Yeah, so if you go to page 380 in Score Builders, there's a Borg dyspnea scale. And so when you first come in to present and see how they're feeling, and they look short of breath, you can go through this scale to see, is it very, very slight breathlessness? Is it somewhat severe or very severe? So this would be a great, documentation, especially in the under the objective portion. Maybe after describing to them what the number scale is and what that means, you can ask them, how breathless do they feel as well? And also just making for sure you look at them to see, maybe possibly what number of the scale they would be. So make sure you review that. I'm really going to look more so at the Borg scale, but there are different scales out there too. So it's good to measure all of these at the beginning and the end of a rehab program or during periods of exasperation. So there's also a modified British Medical Council dyspnea scale and the baseline dyspnea index too. So, and there's also quality of life measurement specific to pulmonary dysfunction. It includes respiratory questionnaire as well. So, especially for those that have COPD, there's an assessment test and different questionnaires that you can look over too. These are all the different factors that could affect respiratory function. So, pulmonary compliance, is there an ease with the lungs inflate during inspiration? Or is there a deficit? Airway resistance. There should be a normal resistance of airflow through the airways. Is there increased airway resistance? Ventilation, a process by which air moves in and out of the lungs, and diffusion is movement of gases in and out of blood. There's also some other factors as well, such as pulmonary compliance. Is there an ease with each lungs on how they inflate during inspiration? Airway, I just said that. Sorry, I didn't go on. Perfusion, blood flow through lungs available for gas exchange. Got oxygen, hemoglobin binding, level of oxygen saturation in the arterial blood. So make for sure you look over page 369 as well, hematocrit and hemoglobin. So adult males is 13.3 to 16.2, and then adult females is 12 to 15.8. So make for sure you know those values for like hemoglobin. There's also common laboratory test as well. You're going to have to know on page 368 what's a normal pH. Some of these will be review, hopefully, from PTA 160, so make sure you know the differences between the, acidemia, alkalemia, hypercapnia, and hypoxemia, and hypoxia. So there's two different. So low level of oxygen in arterial blood is hypoxemia, and hypoxia is a low level of oxygen in the tissue despite adequate perfusion in the tissue. So again, didn't really mention this, but make for sure you're reviewing all those PowerPoint information and all of the resources that you utilize during PTA 160. And so review all of that information because it will come back up in the test. Some other things too, make sure you review all the pathologies that are mentioned in the score builders on page 366 to 367. Asthma, bronchitis, COPD, cystic fibrosis, emphysema, pneumonia, pulmonary edema. So make sure you know signs and symptoms of treatment for those as well. There's also on page 368 what a pulmonary embolism and restrictive lung dysfunction. So review all the terminology for that as well. So go to the next one. So how what is spirometry? So this is with diagnosing. So they use this, a lot of times it might be respiratory therapists or physicians to determine the cause of shortness of breath. They will use spirometry. So to measure as far as like what is going to be the most basic and frequently performed test of pulmonary lung function, and is to see obstructive disease that blocks breathing, restrictive disease that limits expansion and capacity of the lungs. So they will use this to use for diagnosing and monitoring lung problems. Now, if you've ever had surgery, you might have seen one of these before. So this spirometer measures how much air the lungs can hold and how well the respiratory system is able to move air in and out of the lungs. So usually they give you, all these little check marks over here, and I have one and I can show you during lab. But usually you move this yellow mark up if that's what you want their goal to be, to breathe in as deeply as they can to try to meet the mark. Is really what they, when you inhale, it's going to make this float up. So that way, especially after surgeries, they have a chance of developing pneumonia. So definitely want to make for sure, if they're not moving very much, that they are working on this. Same thing with COPD patients, emphysema. A lot of times we will have these because they're not sometimes very ambulatory or mobile. So they want to make for sure that they are not, that they are maintaining their lung function, and that way that they are not creating more of deficits. Okay. So there's PFTs, if you've heard those before. This is a picture of what that kind of looks like, a PFT. There's some different ways too. There's like a handheld. If you go to page 382 to 383, let's see, there's another picture of a PFT test on page 383, and this is a non-invasive test, shows how well the lungs are working, measures lung volume, capacity, rates of flow, and gas exchange. And so this way we could, the healthcare providers can diagnose and decide the treatment for certain lung disease disorders. So make for sure you look over, the procedure. They'll have to maintain an upright position. They exhale into the spirometer mouthpiece as hard and fast as possible for 6 seconds until no more air can be expelled. So there's modern spirometers will predict normal values. The test value the patient should normally attain based on age, sex, height, weight, and race. So after that, they interpret any kind of obstructive ventilatory impairment. And so we're going to look at each one of these. And so pathologies include asthma, emphysema, and chronic bronchitis. And they also look for restrictive ventilatory impairments. Those pathologies would be interstitial lung disease, pleural diseases, chest wall deformities, obesity, pregnancy, neuromuscular disease, or tumors. So on 383, another way to measure oxygen, which you have already used, is a pulse ox. So make for sure that you look over that information as well and how it is interpreted. Let's see, and it talks about if their oxygen saturation 90% in acutely ill patients or 85% in patients with chronic lung disease, activity should be stopped and discussed with the physician before considering or adding increasing supplemental oxygen. So if it's below 90 or below 85 for those that have COPD, you need to make for sure that you're aware of that. Okay. Some other things I'm really, I'm kind of jumping back and forth, so I apologize. But on page 384 to 385, make sure you know the differences for RPE. There's a revised RPE scale that I want you to be aware of as far as like when you're doing different activities, you will, it's used to use effort during activity and to get an idea of the amount of strain or level of exertion the patient is experiencing. And we'll do this with one of your projects. But an RPE of 13 to 14 represents about 70% of a maximal heart rate during exercise on a treadmill or using an ergometer. RPE of 11 to 13 corresponds with the upper limit of prescribed training heart rates early in cardiac rehab. So make for sure that you know how you would use this to interpret or describe intensity of exercise is what this is utilized for. Also, to make sure you know respiratory rate, rhythm, and pattern. So we've already talked about resting respiratory rates, but make sure you know in this book for score builders it says 12 to 20. I know we previously discussed 12 to 18 for adults, but make for sure you know for that as well. And then also common breathing patterns that is described on page 385, such as bradypnea, as a slower than normal respiratory rate of lower than 12 breaths per minute. And also hyperpnea, increased rate and depth of breathing. Hypopnea, decreased rate and depth of breathing. Tachypnea is faster than normal respiratory rate, so more than 20 breaths per minute in adults. So make sure you review all those common breathing pattern definitions. So again, this is another picture of what a PFT looks like. Now we're getting into the nitty-gritty, the lung volumes and capacities. So talking about each one of these, and I've kind of looked at a couple different sources, so you might see things a little bit differently from one source to the other. That's how it always is, right? And let's see, this is on page 361 to 362 in your score builders. So lung volumes and capacities, all the definitions for that, and then you're going to see this chart as well. So we're going to talk about each one of these. But first, you definitely want to know these numbers right here, tidal volume, which would be 500 milliliters. Let's see, I think they talk about that one there. A lot of times they'll talk about it as far as a percentage of total lung volume, or they'll actually give the milliliters as well. So I kind of want you to be aware of both in case you see one source to another. So let's talk about each one of these. So the IRV, since it's the first one that's described over here, you're going to want to look at all these lung volumes and capacities and definitions on page 361 for IRV is inspiratory reserve volume. So this right here, this first line, is describing the maximum amount of volume of air that can be inspired after normal tidal volume inspiration. And IRV is approximately 50% of the total lung volume, okay? And so now it's important to talk about the tidal volume since it was just described. So let's go right here. This tidal volume, as you can see, this is with inspiration as well. So as you can see over here, this is we're going to look at all these capacities as well, but each one of these are going to make up the total lung capacity for each. So tidal volume is the total volume inspired and expired with each breath during quiet breathing. So this is approximately 10% of total lung volume. So this is just normal breathing without excessive inspiration or expiration. This is what's going to measure just that resting breathing rate. Next we'll look at is this FRC, and that's the volume of air in the lungs after normal exhalation. So FRC, there's an equation. It is ERV plus RV makes up the FRC at approximately 40% of total lung volume, so which makes sense. So this is adding this ERV and the RV. So again, the volume of air in lungs that are after normal exhalation. So this ERV, to be a component of that is the expiratory reserve volume. So this is the maximum volume of air that can be exhaled after a normal tidal exhalation. This is 15% of the total lung volume. The RV, which is the residual volume, is the volume of gas remaining in the lungs at the end of a maximal expiration. Okay, so this is describing as if this is normal tidal volume, tidal volume, quiet breathing, and all of a sudden you told them to take a deep breath in and then take a deep breath out. Okay, so this is the forced expiration, this ERV, and that's going to be the expiratory reserve volume, maximum amount of volume of air that can be exhaled after a normal tidal exhalation. And then again, that residual volume is what's kind of left over. What is left over? The volume of gas remaining in the lungs at the end of a maximal expiration. Because when you're breathing in and out, it's not necessarily that you're expelling all the volume out of the lungs. If that's true, then it would probably collapse, right? So imagine a balloon. If you took out all the air out of the balloon, then it's going to collapse. But if you blew it up like a lung, so that would be inhalation, and then if you let some of that air out of the balloon, but not all the way, then you're going to have a residual volume, okay? Then this VC, so this is the VC, the definition for that is vital capacity, the volume change that occurs between maximal inspiration and maximal expiration. So the equation for this, for vital capacity, it's including tidal volume right here. It's including this IRV that we already described and the ERV. Okay, so this is describing all of this right through here, not just the peak, but looking at forced inspiration and forced expiration. So including all of these measurements right here. So this is approximately 75% of total lung volume. So again, the IRV, as you can see here, I'm going to go back to it, is the maximum volume of air that can be inspired after normal tidal volume inspiration. So this would be describing the maximal amount. So if you took a deep breath in, that would be going up. And then if you took a deep breath out, okay, so this would be measuring inspiration, forced inspiration, and expiration. So each one of these is just separating it, right? So this is just particularly looking at the forced inspiration. This is just looking at the forced expiration. And then this is a total of the forced expiration with the remaining volume of the lung and adding that together. Then again, tidal volume is just that normal quiet breathing in inspiration and expiration. So after you look at it, it's not too difficult. It's just more of the numbers and the names, right? I think it's pretty easy to explain what's happening, with these different waveforms of quiet breathing, and then forced inspiration, forced expiration, and then again, quiet breathing again. So make sure you review each one of those and their definitions and what they mean. Very important to know. Let's see here. We'll move on to the next slide. So all these, are maybe a little bit added on to the definition, I didn't really describe, but total lung capacity, going back here, is describing all those level volumes, okay? So total lung capacity is described as the volume of air in the lungs after a maximal inspiration, the sum of all lung volumes. So this is about 6,000 milliliters, the total lung capacity, total amount of air contained in lungs after a maximal inspiration. So it would contain all of those measurements. So each one of these is just basically describing everything I just mentioned, but make for sure you know the milliliters as well. So that'd be 500 milliliters for total tidal volume. The inspiratory reserve volume is 3,000 milliliters. The ERV, which is expiratory reserve volume, again, is 15% of the total lung volume, but then that is describing 1,000 milliliters. Then the residual volume, sorry. So make sure that one would be 1,500 milliliters. It increases with age. So the residual, the amount of lung volume left in the lung, so that's going to be higher. So if you think about that, then the inspiration-expiration rate is not going to be the same, it would be less. It's going to increase restrictive and obstructive disease as well. Inspiratory capacity, so this would be 3,500 milliliters. Along with that, FRC is functional residual capacity, would be 2,500 milliliters. Vital capacity, so maximal inspiration followed by maximal expiration, so which makes sense. This is going to decrease with age, more likely due to the increases of residual volume, and it's going to decrease restrictive and obstructive disease. So again, related to that residual volume as well. So it could be the opposite. There's additional pulmonary abbreviations and definitions as well. So FEV or FEV1 is a forced expiratory volume in 1 second in liters. It can also be measured in 2 or 3, based upon how many seconds as well. FVC is forced vital capacity. That is also described. So the volume of air expired during a forced maximal expiration after a forced maximal inspiration. H plus means hydrogen ion concentration. So make for sure there's also a peak expiratory flow, PEF, the maximal flow of air during the beginning of a forced expiratory maneuver. So make sure you look at all of those additional abbreviations. So again, we've already talked about each one of these. And I've already mentioned this one as well, but I should say RPE, sorry. Determining, so this is on page 380 on score builders. Have to get to it. So, hold on a second. This is dyspnea, so not RPE. Borg dyspnea scale, my bad. So make for sure you know this one as well. So a lot of times, they might have it as almost like an outcome measure. So at rest, how is it? During activity, is it severe shortness of breath? So that way it's a good documentation resource as well. But I just wanted to add in as well, make sure that you're reviewing even the additional information about pharmacology that's on 373 to 374. We've kind of mentioned these before in 160. Know the medical procedures for airway adjuncts. Maybe there's a trach tube, nasal pharynx airway, and endotracheal tube. When we talk about different tubes and IV and that kind of thing, we'll be looking at that. There's airway suctioning, lung transplant, mechanical ventilation, oxygen therapy. So make sure you look at each one of those as well. This concludes our lecture. I hope you guys have a wonderful day. Thank you.